Assalamu alaikum, everyone. Am I audible?
Yes, doctor.
Okay. We're going to start with learning disabilities, and then I'm going to slightly touch upon managements because I've seen results today. Not a lot of people have managed passing, and most of them have been marked in management. And I've spoken about this previously as well, but I'm going to touch up on it again, just so people can get an idea what do they expect in the management section in the exam and how do you go about it. So we'll start with learning disability first, because I feel like it's something that a lot of people don't understand. What is learning disability? What do you do with a patient of learning disability, and how are you going to tackle that? The smartest thing is to read about it on the NHS website, but just a rough sketch about learning disability, just how there is an autism spectrum disorder. So it's a spectrum on which people can either fall as high functioning autistic patients or as extremely low functioning autistic patients. They can be midway somewhere where they have trust issues, somewhere very hyper, like Asperger's side, somewhere very low where they mute and they're not talking. That's autism. So it's a spectrum. Spectrum means there is a range in which people fall, right? In the same way, there's learning disability as well. So learning disability is now called as learning difficulty, not disability anymore. And it is also a spectrum on which people fall. It is never concluded by one meeting or two meetings. It's a proper assessment, just how autism has assessments. That's how learning disability assessments are done. The diagnosis of learning disability is only established afterwards, and then the range is also given afterwards. So autism, you can label someone with autism spectrum disorder, but then you declare what are the problems they have. The same way it goes for learning disability. So if someone has learning disability, they will have an assessment. By the end, they'll be concluded as either someone with mild learning difficulty, with the major learning difficulty, with somewhat really low IQ level. So there are a lot of things that come with the label of learning disability / difficulty. Having said that, how do we navigate through it in the exam when the case comes up that there is a patient with learning difficulty who's here for contraception? There's a patient for learning difficulty whose blood sugar levels have been spiking and doesn't know how to take insulin. Is a learning difficulty or disability patient with any other medication that you have to teach them or somehow introduce it to them and manage them. So how I would have gone about learning disability is that I'll first go through the NHS website. We'll read about it. That's what the patient expects you to know, and that's what the GMC expects you to know as well. So let's just go through the website first and see what we can pick from there. And then I'd share what I feel is important here. Okay. So here we have learning disability affects a person's, affects the way a person learns new things throughout their life. A learning disability is different for everyone. No two people have the same, just how autism is. A person with learning disability might have difficulty in understanding complicated information, learning some skills how to deal with life, learning about how to look after themselves alone. Remember, these three are very important things, and they should be a part of your consultation. Asking the patient that how do they handle general information, what are the methods that they have used to understand information or to understand or to learn things. It is very important that a part of your consultation also carries questions regarding, have you learned any skills throughout your life? And if you did, what was the method that you used to learn the skills? And psychosocial, so who looks after you? Are you visited by nurses? Are you in a temporary accommodation placement for learning disability? Or are you living by yourself? Are you looked after by your family? This is very, very important. You cannot skip these three things in your exam, because that is what will give you a picture of where you're going with the patient, right? If they're in accommodations which are for learning disability patients and they're not living with family or anyone, then it's easy. These accommodations always have nurses who are experts in helping patients get their medications in time, help the patient understand how to take care of themselves. So then it is easy. But if they're living with family or they're living by themselves, what are the ways that they have used to learn for themselves? It's very important that you ask these questions. You will be judged on these criteria. If you don't ask them, there's a possibility you will score lower than expected. What having a learning disability can mean? A learning disability is different for everyone. Again, lots of people who have a learning disability can work, have relationships, live alone, and get qualifications as well. So ask about their education level and if they have attended university, primary education, secondary, what levels, right? What's the support you can provide? Doctors and other healthcare workers might be able to tell if a person has a learning disabilities when they're very young, but some people get a diagnosis later. If you're diagnosed, you may be referred to other health professionals for the support. What causes a learning disability can be many reasons. Profound and multiple learning disabilities, not all domain, but then there are support. Let's see what is the support they can get. So being diagnosed with learning disability is helpful. This is because it can help you with get the support you need. So support is basically with the nurses that you provide them, accommodations that you can provide them, different ways of expert teams visiting these patients to support them. So that's roughly a sketch of learning disabilities. Everyone on board, am I making sense, or is it too new sort of news and stuff for everyone? Just want to make sure everyone's aware of where we're going. Am I making sense? Okay, good. As long as I'm making sense. Now, how do you go about a learning disability patient? Just generally introduce yourself, ask them about their name and age, identity, and then introduce yourself. So don't look at learning disability or any disability as something that, should I tell the patient, is it offensive that they have a learning disability? They have a diagnosis of learning disability. They know they have a learning disability. They know their LD category of patient. So it is not uh, an offensive thing to tell a patient that I have read from my notes that you have LD. LD stands for learning disability. So it's not that sort of a thing. It's very casual. It's very normal. At times, most of the patients themselves will tell you, doctor, I have been diagnosed with learning disability at this age, and I've been struggling with these things. They'll start themselves, but don't expect them to start on the exam date. So you ask them, I've read from my notes that you've been diagnosed with learning disability. Can you tell me when was the diagnosis made? And since then, how well are you supported with learning disability problems? What are the skills that you've developed to understand things or manage yourself? What are your ways of interpreting information? What are the methods that work the best for you to learn things? It can be whether writing, having tags at different places, um, they can have a way of, if someone repeats information to me every 3 months, doctor, I remember it, or every weekly, if someone reminds me of the information, I remember it. That's another way. The third way can be, I can't do it myself, I need support, I keep forgetting, and I'm then coming to the hospital with admissions. That can be the way. So they're telling you what range of support they're expecting from you, right? So try to understand that how are they interpreting information, what are the skills they've developed to deal with their learning disability, and then medication, allergies, medical conditions, before they show to the hospital, how was it managed, and what were the methods that they used to manage that failed. Of course, you need to know about the failing methods as well, so you don't go into them again. And then later, about the psychosocial. So who do you live with? How are you supported? Are there any community nurses or support staff who visit you and interact with you and help you with getting medications, or no, you're on your own? Is it your mother who looks after you? So it'll be either mother or father or a sibling looking after them. They'll either be on themselves. That's the second option. And the third thing is they might be in a accommodation. Accommodations for learning disability patients are different, for autistic patients are different, for old age adults it's different, for psychotic patients it's different. So there are different sorts of accommodations and placements that offer help to such patients. Of course, they are paid by the NHS, but they are available. So checking on them is important because that again shows you where you lie with learning difficulty patients or learning disability. So learning difficulty, learning disability is the same thing. It's exactly the same thing. Now they've started calling it difficulty. It was disability before, right? Having said that, you're done with the psychosocial section, the lifestyle section. Are you able to do your groceries yourself? You're living by yourself. How do you order stuff, or who brings it for you? Do you have enough support? All of that stuff. And then whatever they've told you works best for them, go ahead and teach them with that method, whatever works best for them. So you'll have a regime inside the cubicle. For example, you have insulin of the daytime, 4 units, insulin at night, 4 units. So for example, your patient tells you that, I understand if someone asks me to repeat after them when they're trying to make me learn something. So that works the best for me. So you're going to take that method with the patient and go ahead that, okay, I'm going to repeat, I'm going to say some things. I want you to understand it. And I, to check your understanding and to check that you have learned it, I'm going to ask you questions. I'm going to ask you to repeat after me. So you can go ahead with this method. This is the commonest method that people use. So this is your insulin. For example, the needle is orange in the day. So it's an orange needle for the daytime. Can you repeat this for me? Yeah, orange needle for the daytime. Okay. And you have to use 4 units in the day. Can you repeat that for me? Yes, doctor, I have to use 4 units in a day. So you will have all of this written down. You don't have to say it from yourself. You'll have a paper with you at hand. You'll have probably both the insulin pens as well that you have to show the patient. And then you can go ahead and you can tell them that this is how you're supposed to use it. And then ask them to repeat, ask them to repeat. So even if you run out of time, the examiner will know that you have checked for everything that a learning disability or a difficulty patient needs, and you're going with the method that approaches them the best, and you will be able to go to like a good score on the day of the exam instead of scoring really low in learning difficulty or learning disability patients. What is worse is first saying, I'm sorry to ask you, you have learning disability. Can you tell me what sort of difficulty or disability it is? And what I will do is that I will put a tag on your freezer or a fridge or a stove, all of these things. First, try to learn what is the problem. The problem is not memorization, that they can't memorize things. That is way ahead. Memory problems are way ahead in line. Learning disabilities, they can't interpret information. They don't understand information. And what they're assessing here is your communication skills with the patient, that how well are you communicating with your patient? Are you able to convey the things to them properly in easy terms, going to their level, or no? You're not going to their level and you're making it difficult for them, and you yourself are finding it difficult to sort it out, so you're not able to convey it to the other person sitting in front of you as well. Of course, they're not going to keep any challenging cases in the exam of that sort. That's for sure. But it's going to be easy. The patient herself is going to help you quite a lot. But this is how you navigate through a learning disability / difficulty patient. Any questions so far? No questions. That's nice. That's interesting. Everyone understood so far. So that's learning disability for you. There's nothing much that I can add to it or remove from it. The next thing that I was going to discuss was managements. I said, now, no, Dr. Munir, I can't do a recap. Sorry, I will be uploading this on YouTube so you can hear it there then. But for now, I can't recap what I said. The next thing is managements now. So managements, how do we go about managements? Because everyone gets marked in management section, everyone scores low in management sections, and we don't quite get the hang of what to do in the management. So remember that there are two components of the 8-minute station that you have. One is a data gathering section. Another component is the management section. So whatever data you have collected, implementing it and extracting the information from it and applying it in the management section is your management. For example, someone's lifestyle is something that needs attention, someone's weight is something that needs attention, someone's non-compliance with medication needs attention, someone's taking too many medications because they're very careful, needs attention. So these are different things that you pick through the data gathering section, right? That the patient is unaware of. They have no idea what they've done to themselves, and you are, because you've done the data gathering. Now, how do we implement it? I do understand 7 steps of management is extremely important, where you start with whether you are admitting the patient or not admitting it. The second step is you give the patient information about their diagnosis. You tell them that you will inform the senior. The fourth thing is you give them symptomatic relief. The fifth is you give them specific treatment. The sixth is probably safety netting. And the seventh is follow-up. And I think there's an investigation somewhere in there as well that you insert. So that's sort of 7, 8 steps of management that you cannot skip. But let's rewire this a little bit. Okay. And I'm rewiring it is because when you rewire it and when you think over it, it's easier to do it the way I'm going to say it rather than the way that everyone tends to do it in the exam. So how I would rewire this is that, for example, I have a medicine case and the patient comes in and tells me I have sinus headaches. That's the history that I collect. And it's affecting the lifestyle because they're probably a teacher or they're working somewhere where they have a lot of screen time, or somewhere where it's very difficult for them to manage the headache. It's just really, really bad. Right. How will I go about this cases? The first thing is I will do my examinations on the patient. I'm going to examine the neurological system and I'm going to press on the sinuses, examine the head and see what parts are tender, what are not tender, right? That only makes sense. So you're examining the patient, you're doing what you would have done in a general OPD, outpatient department. The next thing you do is you verbalize your investigations, because reaching a diagnosis just on the basis of examination is stupid. You can't reach a diagnosis just based on your investigation, on examinations or history. You need investigations to support what you're picking up. So that's when you talk about, okay, I'll do examinations and I'll also, order some tests for you. I'll do some full blood counts, liver kidney tests, check your urea electrolytes, and I'll also do an X-ray of the face to see how the air spaces in the face are. And then see, these are the basic tests that you need to make a diagnosis. So if you don't do the basic tests that will help you reach a diagnosis, you will not get anywhere with it. Then the third thing comes where you apply the 7 steps, where you give the symptomatics, specific therapy, you ask the senior, you tell them the diagnosis, blah 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 blah. But again, you've done this, the examiner hands you over, okay, we found that the patient has blocked right nostril, the patient has mucopurulent discharge from the nostril, the patient has tender maxillary and frontal sinuses. Now you have evidence, right? And talking with evidence is much easier than talking without evidence. So now when you have evidence, the first thing you have to do is ask the patient what is worrying them the most. So they'll give you their concern at this point. And when they give the concern, please don't say, don't completely dismiss the concern and say, yes, from what you've told me, what I understand, you have sinusitis. Have you ever heard of sinusitis? No. Okay, let me tell you what sinusitis is. You have 8 minutes. You don't have so much time. Cut it down. Listen to the patient's concern. Doctor, I'm concerned about cancer. Don't jump to giving them diagnosis straight away. Okay, why do you think you have cancer? Because my friend had headache, blah, 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 blah. I'm really sorry to hear about that. I can see why you're worried about cancers, but I examined you and what it looks like and the evidence that I have, it supports that you have probably inflammation of the air spaces in your face and this is called sinusitis. So you have told them what it means, you have communicated it in easy words, you've also given them the word of diagnosis without asking them whether they know what it is or what it isn't, because that doesn't make sense. Again, asking them, they know, they don't know, always they don't know, and then you have to tell them, okay, this is what it means. So you have to give the diagnosis this way, and then you're addressing the concern as well. Okay, doctor, so what will you do for me? Yes, again, now the most important thing for you right now is pain medication, because you mentioned you're in pain. So now you're taking the patient to the concern, at the points which you collected from the data section, that she is in pain and it's causing a lot of problems. You're giving symptomatic treatment, but you're doing it by addressing the concern. I'll be giving you this, doctor, can I get a head CT scan? So I've done an X-ray for you, and we'll do a head CT scan. If you don't get better by the end of 2 weeks, then it can be serious. Again, you're addressing the concern, but you're also telling her that if there is a differential diagnosis, we look into it after 2 weeks. And then she'll tell you, okay, what else? Yeah, what else can you do? Then always start with what is important. I have noticed that on the results, if you have, for example, mucopurulent discharge, this mucopurulent discharge, I'm going to take a cultural swab from it and find out if you need antibiotics. We'll give you that. In the meanwhile, you can do some steam inhalation that really opens the air spaces in the face, and use hot towels, keep them on your face. That will also, take out the crust and the mucus and everything out of your system, and you'll start feeling better. So you've given her pain medication, you have given her lifestyle little tips here and there, and you've also addressed her concerns regarding cancer. This will be impossible if you go ahead with 7 steps of management and you don't let your patient ask you questions. Because if you don't let your patient ask you questions, you will not be able to do a patient-centered consultation. And if you're not able to do a patient-centered consultation, you will definitely score low in the management sections. So you have to very diplomatically deliver your management, where you're giving the important things, but at the same time, you're addressing the concerns as well. You're bringing their focus again to the important things again and again, not dismissing their concerns. That's very important, because when you dismiss the concerns, the examiner knows that you have learned 7 steps, and that's the only thing that you're focusing on, and that's the only goal you want to achieve towards the end of the case. And you miss a very important thing throughout the process, which is patient-centered consultation, which is good communication skills, which is satisfying the person sitting in front of you. And that just affects the results really badly. And that's where a lot of people are marked in the management section. So you can't just go ahead with only addressing concerns and not telling them the diagnosis, symptomatic, specific treatments. And you can't go ahead only with 7 steps of management either. So you have to make a blend of both of them, which is very important, that you make a blend of the two of them. Am I making sense so far? Did I get it across proper or no? Should we mention the things that the specialist will do even without patient asking for what consultant will do? No, you shouldn't. Then again, take your seat back. What is important? What is important is what is going through the patient's head. Is he worried about what the specialist will do? If he is, then tell him. If he's not, then don't tell him. Why do you have to tell someone about surgery when they only have sinusitis, which can be cleared in 2 weeks with antibiotics? So don't go to the places where they're not taking you. Let them take the driving seat, let them drive it around, let them take you where they want to take you. Anything else? Any questions? You guys can unmute yourself if you have to ask questions. I don't mind, because whatever time is left in this session will be questions now, because I had 2 goals to achieve. I've already achieved them. So now we can take questions. I don't know, Dr. Shabana. I don't design the sessions. They just happen whenever I'm free and I decide. Wow, so we have no questions. I mean, that's the end of the session then. Okay. Bye, everyone. Take care and best of luck for the exam.